welcome to The Explainer. Today we're arming you with a high-yield, structured masterclass on chronic obstructive pulmonary disease. We're going to translate complex clinical guidelines into guaranteed exam success for your MSRA. Let's jump right in.
Here is our roadmap for the session. We'll quickly hit pathology and diagnosis, break down staging and clinical traps, navigate stable management, tackle acute exacerbations, lock in some high-yield mnemonics, and finish strong with 10 essential MSRA questions.
Section 1. Pathology and Diagnosis. Let's get right into defining the disease.
So when we talk about COPD, we're really looking at a core anatomical divide. On one side, you've got chronic bronchitis. Think of this as a disease of the small peripheral bronchi. We're talking serious mucus hypersecretion, goblet cell hyperplasia, and thickened airway walls. On the flip side is emphysema. This one strikes deeper, physically destroying the terminal alveolar sacs. That causes a permanent loss of elastic recoil and leaves the air spaces permanently enlarged. They're two totally different structural enemies, but they ultimately lead us to the exact same clinical picture.
Now, what does this actually mean for the patient's breathing? The crucial clinical point here is the nature of the obstructive defect itself. In COPD, we're dealing with a fixed airflow limitation. It's driven by expiratory flow collapse and static gas trapping. This is a massive point for your exams, so keep it in mind. Unlike the reversible smooth muscle bronchospasm we see in asthma, the structural damage in COPD means this obstruction is locked in, it's fixed.
Moving on to Section 2, Staging and Clinical Traps. Let's look at the NICE severity staging.
NICE neatly categorizes severity based on post-bronchodilator FEV1 percentage predicted. You literally need to memorize these three thresholds: 80, 50, and 30. Stage 1 or mild COPD is an FEV1 greater than 80%. But remember, symptoms absolutely must be present. Stage 2, moderate, drops to between 50 and 79%. Stage 3, severe, is 30 to 49%. And Stage 4, very severe, is anything under 30%, or under 50% if they also have chronic respiratory failure. Burn those numbers into your brain. They're the absolute backbone of the staging you'll get tested on.
And before we go any further, you need to watch out for a classic clinical trap. Peak expiratory flow rate, or PEFR, is not recommended for diagnosing or grading the severity of COPD. Seriously, do not use a peak flow diary here like you would for an asthma patient. You absolutely must rely on post-bronchodilator spirometry showing an FEV1 to FVC ratio of less than 0.70.
All right, Section 3, Stable Management Strategy. Let's walk through the stepwise pathway. Here's how we actually build our treatment plan. Step 1 is super straightforward, an as-needed short-acting bronchodilator. That's your SABA or SAMA. But Step 2, that is the critical fork in the road. You have to assess for asthmatic features or raised blood eosinophils. If they don't have asthmatic features, you head down the path of LABA plus LAMA dual therapy. But if they do have asthmatic features or eosinophils, you start a LABA plus an inhaled corticosteroid, or ICS, to help knock down those exacerbation frequencies. Finally, Step 3 is triple therapy. This is where you escalate to a LABA, LAMA, and ICS combo for patients dealing with persistent breathlessness or frequent exacerbations.
And here is a massive clinical pitfall to flag. Never, ever combine a SAMA like ipratropium with a LAMA. Why? Well, it leads straight to receptor saturation. You're basically just maxing out the anticholinergic side effects with literally zero added bronchodilator benefit. If you step a patient up to a LAMA, you have to discontinue the SAMA. Simple as that.
Section 4. Acute Exacerbation Management. Time to cover the protocol.
Flare-ups happen, so here is your acute survival protocol. First up is oxygen. Use a Venturi mask at 24 to 28% and strictly target oxygen saturations of 88 to 92% until you can get your ABG results. This is crucial to prevent worsening hypercapnia. Next is the ABG itself. You're checking for type 2 respiratory failure. If the pH drops below 7.35 despite your best medical therapy, you need to use non-invasive ventilation like BiPAP. For medications, give nebulized SABAs and SAMAs. For steroids, you want oral pregnenolone, 30 milligrams once daily for exactly 5 days. And remember, antibiotics are not a given. You only prescribe those if the sputum is actually purulent or significantly increased in volume.
Moving on to Section 5, High-Yield Mnemonics. Let's look at some rapid recall tools.
I absolutely love these because they save you so much time when you're under pressure during the exam. First is the pre-azithromycin screen, or CELT. Before you ever start prophylactic azithromycin, you need a CT thorax, an ECG, liver function tests, and a TB or sputum culture. That ECG is absolutely vital to rule out a prolonged QT interval and prevent a fatal arrhythmia. Next, we have SLO, for mortality-reducing interventions. What actually prolongs life in COPD patients? Smoking cessation, long-term oxygen therapy, and operative or lung volume reduction surgery. Just think SLO, to slow down mortality. It's a lifesaver.
Section 6, 10 essential MSRA questions. Let's run a quick combat simulation.
All right, question 1. A 62-year-old smoker has post-bronchodilator spirometry with an FEV1 to FVC ratio of 0.65 and an FEV1 68% of predicted. What is the diagnosis and staging? Well, the ratio of 0.65 confirms obstruction, and that FEV1 of 68% slots perfectly into stage 2, moderate COPD. Remember that 80-50-30 rule we covered earlier.
Question 2. A stage 3 COPD patient with no asthmatic features remains breathless on an as-needed SABA. What's the appropriate maintenance inhaler? Think back to that fork in the road we discussed. Because there are no asthmatic features or eosinophils, we're heading down the non-steroid path. So, the answer is LABA plus LAMA dual therapy.
Question 3. A patient taking tiotropium, which is a LAMA, is prescribed ipratropium, a SAMA, as a rescue inhaler. Why is this clinically inappropriate? We literally just flagged this massive exam trap. Combining these leads directly to receptor saturation. You're giving them extra systemic anticholinergic side effects with absolutely zero added bronchodilator benefit.
Let's rapidly fire through the next 4 questions covering acute management and pharmacology traps. Question 4. What's the initial O2 target for acute respiratory distress on room air? The answer is a Venturi mask at 24 to 28%, targeting 88 to 92% until you get an ABG. Question 5. Are oral antibiotics indicated for increased breathlessness with clear white sputum? Nope, only if the sputum becomes purulent. Question 6. Which cardiac test must be done before starting long-term azithromycin? A 12-lead ECG to rule out a prolonged QT interval. And question 7. What is the most common bacterial pathogen in an infective COPD exacerbation? That would be Haemophilus influenza.
Wrapping up our MSARS simulation with some strict numeric thresholds. Question 8. What are the blood gas criteria for long-term oxygen therapy, or LTOT? You're looking for a PA2 of less than 7.3 kilopascals, measured twice, 3 weeks apart. Question 9. What's the recommended duration of oral prednisolone for an exacerbation? It is exactly 5 days of 30 milligrams once daily. And finally, question 10. What ventilatory support is indicated for persistent type 2 respiratory failure with a pH of 7.28? The answer is non-invasive ventilation, specifically BiPAP. Before you head into your exam, remember this core truth. Smoking cessation is the single most effective intervention to slow decline and prolong life in COPD. Despite all our advanced pharmacology, stepping up inhalers, and analyzing complex ABGs, stopping smoking remains the single most powerful tool we have in our arsenal. So, the question I'll leave you with today is, how are you going to prioritize this conversation with your very next patient? Good luck with your studies, and thanks for joining this explainer.